chance to look at this HCG paper, it's fucking exhaustive. It's so long. So I don't know
Yeah,
if you.
I've seen it before. It was one of the studies I looked at a lot when I wrote my book on it because I've been kind of banging this drum for a couple of years and no one
Yeah,
else seemed to care about it. So when I saw you'd picked it up, I was like, oh, good, someone else actually can
yeah,
see what's glaringly fucking obvious. But I think people just
right.
like to parrot the same nonsense. No one actually reads the studies.
Yeah. Okay. So, why don't I have a couple points that I want to go over regarding that paper, and then I kind of want to get your take on those points. So let's just start with that. Okay.
Yeah, cool.
Okay. So this paper is titled, just for folks to understand and go research this. Like, we're not going to give you the entire breakdown because it's multiple pages long. It's just like this big gigantic paper, but it's called Two Hormones for One Receptor: Evolution, Biochemistry, Actions, and Pathophysiology of Luteinizing Hormone and HCG. And basically, what like the authors uh, are contending is that luteinizing hormone and HCG are not only not the same thing, but they both, as at the receptor side and the genetic side, have distinct actions that make them kind of different. And the overarching conclusion by these people that wrote the paper is like all that we've thought about HCG and it being a luteinizing hormone mimetic is pretty much wrong. Like we can't just say that it's the same thing. And they even go on to say that like there's clinical data lacking on like the distinct differences between luteinizing hormone and HCG in men where this matters. So, a couple points that I wrote down regarding this paper, then I'll get your take on it. Number one, they say LH and HCG as ligands for the same receptor suggests that a separation of hormone specific roles occurred, resulting in different hormone specific physiological functions. Then they go on to say LH and HCG specific actions exerted at the molecular level are underpinned by different molecular structures associated with each hormone, which arise from a different set of related genes, along with a source cell dependent post translational modification. So that's implying that the genetic sequences after receptors are bound to are different. They go, although previously considered equivalent, both hormones divergently evolved in primates and are characterized by differences at the genetic, molecular, and physiologic level. Couple more points here quickly. They go, in males, Leydig cells in the testes are targeted by a luteinizing hormone, which we know, which induces testosterone production as the major synthesized androgen. Then they go, luteinizing hormone is therefore essential for reproduction in both sexes. In contrast, HCG physiological action is only exerted in females as a massive progesterone stimulator in the corpus luteolum and mediating placental growth during pregnancy. This is something, Dave, you've talked about a lot. How we're referring to you refer to it as effectively a pregnancy hormone, which it really is. Then they go on to say it is not produced in males. Last point. They say the greater binding affinity was suggested for HCG when compared to luteinizing hormone. So your HCG has a greater binding affinity for the LH chorionic gonadotropin receptors in the testicles. So in and of itself, that makes it different. They say owing to its longer persistence at the receptor level and greater half-life of the bound hormone, resulting in a dissociation rate, a reduced dissociation rate for HCG, meaning it sits on the receptors for fucking longer. These results suggest that the two hormones interact differently with the receptor as a consequence of distinct amino acid sequence. Okay, so that's all the the scientific stuff I'm going to read. God, that is saying that like this general idea, Dave, that we've had about HCG over the years, that it's just LH mimetic and it's like perfect for TRT, is not only wrong, but it's like these hormones are distinctly different. What is your take on that? Like, what do you have to say about some of that shit?
Yeah, so I'm very glad that you're bringing this stuff up and bringing this to people's attention because HCG being an LH mimetic is one of the main myths in TRT. And the idea that something is a mimetic means that it does the same thing. That's what it literally means to mimic something. And as you know from your work with nootropics, just because two things bind to the same receptor doesn't mean they exert the same biological effect. HCG is as much of a luteinizing hormone mimetic as LSD is a serotonin mimetic. They're not the same thing. If you replace someone's Zoloft with a tab of acid, they're not going to have the same day. So
Right.
it would also be like saying that Masteron is a testosterone mimetic. It's an androgen receptor agonist, but it does different things. It does some of the same things, but it does a bunch of different things. And
Mhm.
if luteinizing hormone and HCG were the same thing, then all men would tolerate HCG very, very well. So I think from practice, when we see a lot of men just react quite in a quite feminine way, honestly, to HCG, it's pretty obvious they're not the same thing. And it wouldn't make any sense for them to be. There would be no reason for a pregnant woman to start making HCG if it was the same as luteinizing hormone. So we have to look at, and as you've correctly identified, all we really know about HCG in men is that it stimulates the Leydig cells in the testicles. We don't have any idea what it does in the brain, the central nervous system. We have no idea what it does. We have no idea what happens if you take this for a lifetime. I mean, women only produce this while they're pregnant. And I think that that's quite concerning. And my argument, which is what I made in the Beyond TRT lecture, is that it creates a bit of a catch-22, which is going, okay, is it better to leave the receptors dormant, which I don't think is ideal either, because TRT is
Right.
not a perfect thing. So is it saying, well, do we leave these receptors dormant and see what happens? Or do we stimulate them with something that we don't really know what it does and it probably doesn't have a place in a male's biology? Which one of these is better? And it's like, well, in every study on testosterone, they've left it dormant, and all the positive effects have been when we've left it dormant. So I think the idea of stimulating these receptors could potentially cause more harm than good in the long term. And one of the things that this paper identifies is that HCG has a stronger biological effect on cyclic AMP. And that makes
Yep.
sense because if HCG didn't upregulate the metabolic function and energy systems of the body, when a woman started growing a baby, she'd just lay around all day. She'd be exhausted. She wouldn't have any
Yep.
energy. So it makes sense that it biologically does different stuff. And I would argue that the distinctions between the two hormones are the factors that lead men not to tolerate it.
Yeah, sure. Yeah, whatever those mechanisms are and whatever is happening is causing side effects that, people often do get on HCG and we have no idea what they are. We have no idea what they are. Like, so some of these unexplained, like I have a guy who, I mean, he's got to take like 55 IU every other day of HCG because 150 or above or 100 IU and above at any time, he just gets anxiety,
Yeah.
and we can't really pinpoint that. We can't really couch that as estradiol mediated, right? It's
Mhm.
something else. So, so let me ask you this. We know LH and HCG are different via this study and via a lot of your work, but like, do you attribute some of these negative effects that people get on HCG to the simple fact that it stays around at the receptor longer?
It's a great question, and it's
Yeah, because
definitely
I mean,
the
like luteinizing hormone is pulsatile. It's pulsatile. It has somewhat of a long half life, but you're just getting micro amounts at a time. With HCG, even in smaller doses, you are blasting the luteinizing hormone chorionic gonadotropin receptors with far more material for far longer.
yeah. So I've been trying to work this out for a long time because one thing that bothers me about HCG is that if I give you 50 guys who respond well to it and 50 guys who respond poorly to it, I haven't been able to isolate what the variable is that these guys have in common or these guys have in common. And
Right.
that to me irks me. It seems to be a roulette. And I do wonder if the guys who respond better to it are maybe less self aware that it is subjectively causing them problems. I do question that. Um, it's a tricky one. I think, and this is just purely the overarching point is I don't know, but my hypothesis is that I also think that that may be a factor. I don't think the stimulatory effect on the thyroid is a factor because I've never seen it induce hyperthyroidism in men.
Mm,
It definitely does upregulate the thyroid, and I think that. And one of the points that I'll make is that every single guy, and I mean literally every single guy, who has come to me and said, I need HCG to respond well to TRT, had subclinical hypothyroidism. So I think the
mm,
thyroid is more of a mechanism as to why some guys do well with it.
mm.
But I think that HCG crosses the blood brain barrier and has a psychotropic effect. That's my theory.
Right. Sure. Sure. Yeah. Expand upon your idea of it being feminizing. Are you having guys report feminizing like side effects? Like what are we talking about? Like changes in fucking sexual orientation, or are they generally finding themselves being more feminine in the presence of women? Like, what? I haven't seen that personally, but I don't really ask men about that sort of thing.
Yeah.
What have you seen in that regard, or are you just referring to it as a feminizing hormone because it's like, it is predominantly in the progestational period of a woman where it gets released and does a lot of its actions?
I see HCG in practice do two things. One is that guys will often say that they feel like, let's say they start on TRT, they feel better, and then they add HCG and they feel worse. They'll often say that they feel more like how they felt before they started treatment. It's kind of like they
Ah,
lose a lot of those androgenic benefits, which when
right.
you speak to them about, and they articulate what does that mean, like testosterone tends to make men more confident, more stoic. It calms that inner monologue a little bit, makes men more driven and assertive, but not in like a pro-confrontational bitchy way, but more in like a I'm true to my moral compass and so forth. A lot of the time, they'll find that they develop quite a lot of anxiety. Exactly what you said, anxiety.
Yeah.
This
Yep.
feeling of this impending sense of doom, feeling insecure, feeling threatened, feeling judged, feeling all these things that psychologically, to me, I would attribute as feminizing.
Sure.
But also, kind of like what you said and what a lot of people have spoken about, the dominant theory for a long time, and it might still be, is that HCG produces these estrogenic effects because it produces more intratesticular aromatase, which aromatase inhibitors are not able to block. I don't think that that's true. I think that's a bit of again, it's a theory, but I don't think that it's a theory that has much merit. But it
Now
seems
you can have someone with 45 estradiol with 150 IU HCG every day and 150 milligrams of testosterone per week and 0.25 milligrams of Arimidex every fourth day, and their estrogen is still going to go to 12, regardless
yeah,
of whether they. So
yeah.
so yeah. I mean, there's this notion that the testicles might be the aromatization might be somewhat resistant to AIs. Maybe that's partially true, but if you look at people's blood work, you can crash your estrogen on fucking 1,000 IU of HCG every day if you really wanted to.
And you still don't get the side effects go away. This is what guys have found in practice is that if they feel like they're getting these estrogenic side effects and they take an AI to bring that down, it seems that then they just get low estrogen side effects and high estrogen side effects at the same time.
Yeah.
So it's like you've got joint pain, but you're crying when you're watching the Avengers, and it's
Yeah, yeah, yeah.
I just
Ridiculous.
think the way that I look at it, and again, this is something I've thought about a lot. It's purely non-scientific. It's just kind of looking at it pragmatically. Is that it's from an evolutionary standpoint, it was very important for the pregnant female to survive. So she needed to be hyper vigilant, hyper aware of her surroundings. And I think that the behavior modification that comes from HCG and the psychological effects might have something to do with a survival mechanism in women who need to keep alive when they're pregnant. Maybe that's something to do with it. The big factor is we just don't have a fucking clue because no one's looked at this. We don't know what it's doing.
Yeah. Yeah, you're right. I often think about well, like what is the next step for Cortex Labs? And there's a lot of ideas that I have, and I'd really like to try to get into filling the void in these bigger problems with TRT that no one wants to put 5 to 10 years into. As an example, getting an alternative to HEG,
Mhm.
or getting an alternative to AIs, as an example, like that may for estrogen sensitive people just lower estrogen a very fucking little bit. And
Mhm.
so, yeah, man, I mean, this is a big issue. I forget where I was going with that, but yeah, I mean, I think I think, like you said, TRT is just not perfect. I often find myself having to bring in a bunch of ancillaries just to dial certain individuals in. Some guys, 200 milligrams a week, testosterone cypionate or testosterone enanthate injected on a Saturday. Perfect. They're perfect. Other guys, side effects or the sexual system goes awry. If we lower the dose, then the sexual system works, but then they have no energy and they're not anabolic. And so, yeah, TRT is
Mhm.
definitely not perfect. And fucking HEG is far from perfect.
Yeah, TRT has got its limitations, and I think a lot of guys, because TRT is becoming more mainstream, they're getting on TRT with some kind of different expectations about the fact that it's a flawed system, and we're working. I mean, TRT a decade ago was much more flawed than it is now. I mean, we've refined it leaps and bounds in the last decade. It's come a huge way, but
Yeah.
there are these limitations to it, and the challenge that I think a lot of guys have is realizing that when they go on treatment, they feel like there's something off and they don't feel quite how they need to feel. And I think that's why it's so important that rather than just saying, oh, well, you need a female pregnancy hormone because of this upstream hormone hypothesis and all this kind of stuff that isn't really founded in any science. I think it's much better that guys are getting to the root cause of maybe why their TRT is not working for them properly. And in my experience, a lot of these guys, they do have these teething side effects. Like you mentioned that a lot of guys need ancillaries to get dialed in. They'll often find that they need those ancillaries at the start, but then once the body adjusts to it, they get this kind of prolonged exposure to the androgens. They kind of just let it settle and those side effects go away. I think the body often needs a lot of time to properly androgenize from the treatment. And when guys have been on it 5 or 6 years, they look back and they go, oh, yeah, it was just this kind of teething adjustment issue.
Yeah, definitely. Yeah, I mean, there's that happens on a micro scale and on a macro scale.
Yeah.
Definitely. Like, I mean, some guys will be okay if they leave their protocol alone for 6 weeks. But I have a lot of guys that come to me that are just hyper. They just want to change things in a week and a half or something. And
Hmm.
so that keeps them in a purgatory, an endless purgatory of never dialing in. And even though some of these guys are like, they're my clients and I'm the consultant and they're the consultee and they're supposed to be compliant with what I'm suggesting, they'll still make changes and be like, hey, I did this and then this happened, then I
Hmm.
kind of have to respond to it. So yeah, it's a good point that like you do androgenize over time. I certainly feel different at year 4 on TRT than I did at year 1 on TRT. And just a tip for folks, like if you're having a hard time dialing in, you're actually going to find on the testosterone subreddit an anecdotal that reflects this. One guy was like, I just left it alone, I just stopped changing it. The topic was like, what gave you your libido back on TRT? And one guy was like, I just stopped fucking with it.
Yeah. Yeah,
So
and
yeah.
the great thing about your channel, I mean, you've been making videos since as far back as I can remember on different topics. And what people can do, I mean, if they want to see the effect of TRT on 4 years, just go back and watch your older videos. I mean, you can see
Hell
that
yeah.
you look significantly different every year that you've
Right.
been on it.
Yep.
And sometimes and I think that's great, when you're making videos and you're documenting this journey, is that guys can see and go, oh, this is something that just takes time to work. I mean, I often use the analogy of puberty. Like, if you have like a 13-year-old come in and be like, why aren't I a full grown man yet, to his father, he'd say, well, puberty takes years.
Yep.
TRT takes years. It's that prolonged exposure to androgens that morphs
Yep.
you into a different version of yourself. And
Definitely.
you just got to be patient. And I'm totally going to soundbite that clip and put it in my group, because it's the same thing I keep saying to all my guys, is that if I say go away for 8 weeks and do this and don't fuck with it, it means don't fuck with it. It doesn't mean, oh,
Yep.
I watched this video and I'm trying this, and watch this video and I tried this. Because a lot of the time, what the body needs is to find homeostasis, to find
Yep.
balance. And that's why it's so important that guys get their protocol dialed in. They put it on the back burner, they set and forget, and they go and live their life. They go and practice the healthy habits, the nutrition, the training, all that kind of stuff. And then they
Right.
tweak it strategically, periodically, rather than constantly wanting to change things all the time. Because at the end of the day, the process is going to take time, and the more you fuck with it, the longer that process is going to take.
Yeah, totally. And then hormone receptors take some time to exert their changes on the either androgen responsive genes or otherwise genes, and yeah, that could take 4 to 6 weeks, especially relative to libido and sexual function. I mean, these things, like if I change a protocol, like I'm coming off cycle, or I don't know, I'm like the first time I tried testosterone and theta, I'm like, oh, I'm gonna run this protocol and then change it. Like I don't feel the same at week 4 as I did at week 2. So if at week 2 I had this premature impulse to change the protocol, I might have fucked myself. Whereas at week 4, everything's good. So yeah, that's just one point that we want to we want to influence people to understand. Like, yeah, stuff takes time. Back to HEG. So I guess I've heard you and some of the other folks on the TRT hormone channel. I think Keith Nichols subscribes to this theory that as long as you take DHA and pregnenolone, you're okay. Now, I haven't seen that to be the case because people have cosmetic issues. They got testicular shrinkage. I have a couple guys that get like their junk dries out without
Mm.
HCG. It just dries out. Everything else seems to function well, but there's like less moisture. Can't fucking explain what the hell's happening there. But like, I mean, what are your alternatives? If a guy comes to you and he's like, man, HCG really just makes the sexual system work, may come with some estrogenic side effects, so I got to manage that or lower my testosterone dose. But yeah, it's causing side effects, and I want to try to get off of it. Like, what would you do?
Yeah. So one of the big factors around this, and again, it comes back to this recognition of that TRT is not perfect. It does have drawbacks. I don't think anyone except for cyclists would like to have smaller testicles. So it's not ideal. It's not a deal breaker, but it's not ideal. One factor a lot of guys have is that the testicles will pull up into the abdomen a lot of the time,
Yep.
particularly during
Yep.
sex, and that can be, quite physically uncomfortable.
Mhm.
One of these solutions for that is to increase the flexibility and the range of motion of like the adductors, to relax the pelvic floor, to practice things
Mm.
like hip and groin stretching. A lot of the time, there is dysfunction in the pelvic floor due to just poor function of the posterior chain that a lot of these guys need to resolve just from sitting all the time, not doing proper mobility work. And then when the testicles get a bit smaller, it will cause that retractile testicle function to be able to occur more often. So that can
Mm.
be a little bit of a workaround for that. When it comes to the issue with the genitals itself, like I've definitely had guys mention that they feel like there's not as much sensitivity in the penis. Ejaculate volume can get smaller.
Oh yeah.
There's definitely stuff like that that some guys report, other guys don't, which I find kind of interesting. It's interesting that
Mhm.
some guys will say, my ejaculate volume is half or a quarter what it was before, but other guys like myself, I mean, I've never encountered that issue personally.
Mhm.
And it's tricky. I think a lot of guys do need higher levels than what they're taking. And you mentioned Dr. Keith Nichols before. He's an advocate of pushing the levels higher when needed. I really
Mhm.
believe, and so does Keith and a few other of my colleagues, that exogenous testosterone doesn't work as well as endogenous testosterone. If you have a
Sure,
natural
I agree with that too. I agree with that
completely,
100%.
and we don't know why that would be, but it just makes sense. If you're not making it internally versus taking it exogenously, it's not going to
Yeah.
work at the receptors in the same way. We don't know how that is, but we observe that. And I find that a lot of the time guys need a higher dose, and then to tolerate the higher dose, they may need a different form of administration, like the transscrotal cream, more frequent injections than maybe they would ideally like to do, but sometimes that's just what's required. But those are the factors that I find help the most. And then if there is a pregnenolone and DHEA deficiency, I've never seen HCG fix that. I've never seen someone with a deficient DHEA take 100 units of HCG a day and then it brings the levels into a therapeutic range. I've
Yeah, I
never seen
think you would need a whole lot of HCG in order to move the numbers
it.
there. I've seen similar blood work where it may move a couple points one way or the other. I've seen guys progesterone go down a little bit on HCG, which is hard to explain. So, yeah,
Yeah.
I see that as well. So, DHEA and pregnenolone, though, alone with TRT, do you find that in the right doses helps some of this testicular function, potentially shrinkage and load volume? Have you
There
seen that
are
or no?
some studies in animals that show that pregnenolone can be protective to the function of Leydig cells when exogenous
Yep.
testosterone is administered. I think
Yep.
the human equivalent would be well over what we would typically be using. Um,
Right.
I've become a lot more like I've kind of gone back and forth a lot on pregnenolone and DHEA. I've made a lot of content on it. I've spoken with a lot of different providers about it. One of the things that I'll mention for your audience, if they do want to try it, the difference between a non-sustained release version versus a sustained release version is significant.
Of
These
pregnenolone.
pregnenolone or DHEA, yeah.
Okay.
Yeah. So that makes a big difference because, particularly with pregnenolone, for example, is that we know that when progesterone goes too high in men, it becomes anti androgenic. It downregulates 5 alpha reductase. Your audience knows that that's not a good thing.
Yep.
And it also can block and reduce the sensitivity of the androgen receptor. Both of these things are like literally the opposite of what we're trying to achieve. And if we're having big spikes in pregnenolone and overconversion to progesterone, then that can also cause these anti androgenic symptoms. So if
Yep.
guys are looking at their levels and they're seeing it's suboptimal and they're wanting to try it, it's really, really worth speaking to whoever's prescribing it and seeing if you can get like a micronized sustained release version. The difference between that and what you get off iHerb or Amazon is
Right.
massive.
Yeah, I bet it is. I bet it is. Yeah, just the micronized DHEA alone compared to regular DHEA is different. It just hits different for sure,
Absolutely.
and it affects the sexual system for me personally a lot differently. What would you say to people? So this notion of needing higher testosterone, that's something that on cycle I realize I can tolerate 4 or 5 thousand nanograms per deciliter for a certain period of time of test.
Mhm.
As long as for me personally, I can keep my estrogen in somewhat control, just not completely going out of control, then everything else functions okay.
Yep.
But I really sort of crossed over to look. Some people do need higher levels of testosterone. In my work with people with PFS and sexual dysfunction, that's almost always the case with these guys is that they need
Mhm.
it. But the problem we often run into is they need a certain level of androgens, but it always raises estrogen in a way which starts to inhibit erections specifically. So what do you and Keith say about that? You guys do seem, especially Keith seems to just like deflect off the topic of the known studies of estradiol inducing venous leakage as an example, right?
Yeah.
Like it can't just go up to 100. So like if people need higher androgens, what do you guys do
Mm.
in
Yeah.
that
So a couple.
case? If estrogen is causing like dick problems or libido problems.
Yeah, so a couple of points I'll make. Firstly, the content that you're doing on PFS is fantastic. A lot of the guys who come to me to speak about it will often bring up your videos. So it's great that you're doing that because there's unfortunately more and more guys every year who are getting wrecked by that medication, and it's
Yeah,
definitely treatable, and we're starting to learn and understand how to treat that better. So I think what you're doing there is fantastic. Um, I can't speak for Keith, but we are pretty aligned on it. So I won't put words in his mouth. But when guys need higher levels of androgens, there's two ways to go about it. One is daily injections, but the better option is cream because cream
mhm,
converts so much more to DHT and so much less to estradiol. And when we're
yep,
looking at the role of estrogen and DHT in the body, they're basically like antagonistic forces. They are, counterbalancing one another. So
yep,
I find that the cream, if guys are wanting to push their levels up significantly higher, like, if you're taking, X amount of milligrams of testosterone to reach, 5,000 nanograms per deciliter, most people would need to inhibit estrogen, whether it's via an aromatase inhibitor or via like a DHT based compound to balance that out.
yeah,
Some guys find that testosterone, like estrogen, gets left behind at a certain point and testosterone goes through the roof, but that's not the
yep,
case for everyone.
yep,
But I find that for these guys who are more sensitive to what we would call the estrogenic side effects, the cream is what allows them to tolerate the levels that allows that to reach a therapeutic point for them. And some guys don't like the cream in terms of putting it on and transference and stuff like that. But if that's what's needed, especially if they've got like PSSD, which I think is a big factor as well as PFS, sometimes that can be a game changer. Because for me personally, and we spoke about last time my previous use of Proviron,
yep.
cream for me feels like test plus Proviron
Yeah,
subjectively.
yeah, yeah. Oh yeah, I mean, there's no question that the higher the DHT level, the better all of this is relative
Mm,
to people that have problems with estrogen. Like, I'll give you
yeah.
an example. I can dose 70 milligrams of testosterone propionate and rub 3 pumps of transcranial cream on every day. That's like a total of 600, 700 milligrams a week or so of androgens, like fucking basically like a cycle level of fast acting testosterone modalities. So it's super unusual. And though I'll need like a little bit of zinc to control the aromatase expression and or a little bit of masteron, a little bit of primabol, just like very fucking low doses of stuff that inhibits aromatase.
Yeah.
I can get away with just zinc and things function pretty good. And the crazy thing is like my erections are better to to get super personal. They're fucking crazy on 70 milligrams of prop a day and 3 pumps of cream with a minor bit of estrogen control. So it's like if I was at 250 milligrams a week of a long ester, I would need more estrogen control. So
Mhm.
that's a good example of how just sky high levels of DHT and a lot of bioavailable DHT
Yeah.
that when it's disassociating from the receptor, you're just getting more. You're just getting more after it disassociates. And as the androgen receptors, reproduce because they basically get, cleared out by these proteasomes each time the genetic sequence
Mhm.
happens, then you kind of have a steadier state of DHT, which really does help. So for
Mhm.
sure that makes sense. So that's your answer. Like just have people siphon more testosterone to DHT.
A couple of other points as well, just to piggyback on that, and again to come back to a lot of what Keith has taught me and what our mutual mentor Neil Rousier has taught us both. When we're looking at this whole idea of, and again, if we're speaking purely within the context of TRT, not super physiological doses, because that's different context, but the idea is that estrogen should be a self-regulating production of hormone, i.e., the aromatase enzyme should find the balance that it should find. The problem is that a lot of guys have disease states which will upregulate the aromatase enzyme, particularly being overweight, liver issues, so on and so forth. But The other thing that I'm very interested in is one that, and what Keith practices is full hormone optimization. So testosterone, vitamin D, melatonin, thyroid, pregnenolone, DHA, everything all together.
Uh,
So
okay, so he's giving people thyroid like T3 or T4 in some of these cases. Is that what you mean?
So Keith primarily works with an older patient population who have multifactorial age-related hormone decline. So you're looking
Yeah,
at
yeah,
optimizing all hormones to the therapeutic level.
right.
And so, for example, pregnenolone is one of the molecules in the body that will regulate aromatase production. So pregnenolone, before it converts to progesterone, is actually an aromatase inhibitor endogenously. The other
Mm,
thing that's important, though, the one that I'm really big on, which I wouldn't be surprised if I see go down the rabbit hole on this, because I think you'd really like all the research, is that
metformin.
T3 does a few really important things. It
Yeah.
upregulates the androgen receptor, it downregulates the estrogen receptor, and it also downregulates the internal production of aromatase. So one
Huh.
of the things that I've noticed is that if a guy can't tolerate the amount of testosterone that he needs, if he wants his testosterone to be at the upper physiological limit of what he could be making as a man, he needs to have optimal thyroid function. And a lot of guys who I see have just mild, low grade subclinical hypothyroidism, which, on 120, 150 milligrams of injectable testosterone a week might not be a problem. But when they start to push their dose up, they then need the thyroid to be optimal to be able to metabolize and tolerate that properly. And I found
Mm.
that this is the big factor that will often resolve a lot of these underlying issues is optimizing the thyroid.
So, are you suggesting that with subclinical hypothyroidism, that you know people are having clearance problems with testosterone, that they can't clear it adequately enough or fast enough? Like, how does having higher levels of thyroid hormone allow people to deal with higher levels of testosterone specifically? Is there
Yeah.
mechanisms for
So
this? Do you have ideas about that?
yeah, so I think there's a multi. I'm really into this concept of the endocrine system and physiology being this series of interconnected systems. And
Right.
one thing I know you've done a lot on is prolactin. And so
Yep.
one thing we see a lot when someone is mildly hypothyroid is they overproduce prolactin. T3
Yep.
reduces
Yep. Yeah,
prolactin.
that's in the literature as well. Yep. Yeah, actually, I mean
Yeah.
that in and of itself can cause pituitary tumors. That's like, there's one case study in the literature which tells us that people like there's this subset of people with prolactinomas were extremely hypothyroid. And the moment they got on thyroid medication, the prolactinoma resolved, which is crazy
Mhm.
because that shit you have to treat with D2 agonists otherwise.
Yeah, yeah, and those D2 agonists, I mean, they case by case. So one thing that I think when we're looking at this kind of interconnected series of systems is going, how can we influence this chain further upstream so that the rest of the system self-regulates in the way that we want it to regulate? And
Mm.
Ray Peat was very big on this idea of the this bioenergetic approach to health, which was that healthy energy metabolism reduces stress on the body, and when you reduce stress in the body produces energy better. It's less stress. I look at aromatase and estrogen as stress hormones a lot of the time because the thing that estrogen and cortisol have in common is they're both anti-inflammatory. So the
Mm.
body is upregulating estrogen and cortisol to try to reduce inflammation when the body is in an inflamed state. So if the body is constantly running in a hypothyroid state, you're going to get this upregulation of prolactin, upregulation of estrogen receptors, downregulation of androgen receptors, upregulation of aromatase. And then if prolactin is elevated, you're going to get downregulation of dopamine production and downregulation of 5-alpha reductase.
Yep.
That's a shitty fucking baseline. If you can
Terrible. Terrible.
flip all those around and the individual tolerates the thyroid well, then we can take them from average to low thyroid to optimal thyroid. Now they're in a situation where they're feeling a lot better, their energy is a lot better, they can lean out, so they can drop the body fat down a lot more as well. But internally, the receptor expression of androgens to estrogens changes. And I think
Yeah.
that this is a big factor. And, from what I've seen in practice, a lot of the time when these guys are coming in and you're looking at their labs and you're going, well, I've seen 20 guys before you who had the same estrogen, the same testosterone, and they weren't having these subjective side effects. And
Yep.
then
Yep.
lo and behold, their TSH is at 2.9, 3.1, 3.2. Their waking temperature is low. They've got a mum who's got Hashimoto's hypothyroidism. And what can often be the thing that resolves this for them is just taking a low dose of either T3 and T4 together or natural desiccated thyroid to support
Yep.
their
Yep.
thyroid function.
Yeah. Interesting. Yeah.
Mhm.
I can't say one way or the other if having thyroid stuff in the picture influences my protocol, because I've been on a desiccated thyroid supplement. It's not prescription grade, but it is pretty fucking powerful, from New Zealand for like 5 years. The shit's very. I wouldn't go without it. It honestly
Yeah.
like upregulates my energy a lot. So
Mm.
yeah, I mean, there's definitely something to it. Again, you have to look at all these things. So your position on this is just the body relative to hormones is they all work together, and if one is lacking, particularly thyroid hormones in this case, then you're going to have a negative response to higher loads of androgens if you need those higher loads of androgens.
100%. And my theory behind that is that I think a lot of the endocrine disruption that occurs from like the plastics, pollutions, pesticides, all of these endocrine disrupting chemicals, I think that that is just as deleterious for the thyroid as it is for androgen production. So when we get these
Yeah,
younger
sure.
guys who shouldn't be low T but are, a lot of the time they've also got a bit of subclinical hypothyroidism going on. And I'm very big on like the thing that I don't like, the pendulum always swings too far in either direction, right? So it went from when I started TRT, everyone needs an aromatase inhibitor. That was the dominant paradigm.
Yeah.
And then it went to we should never test estrogen ever. And it's like, something in the middle here. So in Australia, we always test estrogen. It's part of the same panel. So I've seen just as many estrogen levels as I've seen testosterone levels, which for me is useful. More data, the better. The thing that's really important is that if it's really important that these guys who are going, hey, I've got side effects, I don't feel well, I've got gyno, I'm crying all the time, I'm bloated like the Pillsbury Doughboy. We can't just turn around and go, oh well, it's not estrogen, everything's fine. It's like, well, just because maybe an aromatase inhibitor might not be the best option long term, it doesn't mean that they don't have a problem that we need to fix and resolve. And my strategy for resolving it is looking at it being like, if we're looking at testosterone replacement therapy as restoring the correct amount of androgens that this man should have to be healthy and thrive, he shouldn't need to block estrogen production. If you take a shit ton of testosterone, then yeah, you kind of do. That's just part of the territory. But if we're
Yep.
putting optimal testosterone into a man, that should be well tolerated. So why is it not well tolerated? And then what can we do closer to the root cause to fix this? And I've found that when it's not non-alcoholic fatty liver disease, too much alcohol, or just obesity, it's hypothyroidism.
Yeah, for sure, definitely. Yeah, man. I also think that esters metabolize differently. Like, one way to reduce bloat for people that are running cypionate or anethate is just to stop taking it and to run testosterone propionate or testosterone cream. I mean, every time I switch from a long ester to a short ester, I'm pissing for like 2 3 days. It seems a little catastrophic in the beginning, and then it kind of levels out. But like my face is noticeably leaner. Everything's noticeably leaner. Whenever I'm running, I'll call it slightly higher than TRT doses of a long ester in the
Mhm.
gym, I look fuller. My muscles look fuller. That's because I'm holding a lot more glycogen and water. Whereas if I'm running the same dose or even higher doses in some cases of testosterone propionate, I don't hold that water. I don't hold that water. So, it is difficult to tell whether or not, like with prop as an example, if you are aromatizing generally over a 48-hour period less, or if like you're just not constantly aromatizing, you
Mhm.
aromatize from the peak. Then there's a God, I forget the phrase. There's some phrase in physiology where like the aromatase enzymes get saturated to a certain point, and they can't aromatize continually, even given a substantial load of testosterone. So maybe
Mhm.
that's the case and that happens. But either way, if folks are having problems with that, for sure switch to prop, and you're going to, I think the estrogen burden will be a lot less, even though you might have 65 picograms per milliliter of estradiol or over the range in your guys' range over there. But there's something to some of these fast acting esters that it just makes the burden a lot less.
I couldn't agree more that the esters make a big difference. And like one of the things again that we simply don't know, like we don't know if it's different liver enzymes that are responsible for metabolizing enanthate and cypionate. We don't know that. We have no idea. We don't know which one metabolizes which. We don't know which enzyme metabolizes prop. I get guys all the time, and I'm sure you've spoken to guys as well who are like, I feel terrible on enanthate, but I feel great on cypionate. And you're looking at it being like, well, that shouldn't be the case. It must be
Yeah.
placebo, something like this.
Right.
But there could also be that one guy is not metabolizing that ester well and the other guy is. The
Yes.
one of the reasons why I like cream, and I was speaking with Dr. Eric Serrano about this at the Silverback Summit, it's one of the reasons he likes it as well, is that when you take a injectable version of testosterone, that what gives it the prolonged half-life is the ester, which gets cleaved off gradually in the liver. The cream goes straight into the bloodstream, and prop is more like cream than it is like cypionate because the ester is very short. And I wonder if that bottlenecking in the liver, although it makes it more convenient to inject less often, is that good for your physiological health? Or could this be leading to the things like the water retention and these other problems? Maybe even not via estrogen or just via the fact that it's happening in the liver. I mean, we don't really know. And Neil Rousier, who's just put out a fantastic book called Hormones Demystified, he specifies that the reason why he likes cream is that you're not burdening the liver with this ester that's constantly having to be metabolized all the time. So I've noticed the exact same thing. And one of the reasons why I like cream so much, if it's a high quality 20% HRT based cream or liposomal if that's not available, is that if you take this cohort of guys, the guys who are a bit too overweight, they've maybe drinking a little bit too much alcohol, or they've got chronic pain issues that increase prolactin. These are the guys who usually don't tolerate the testosterone as well. They get the side effects. But if you use the cream with them, all of a sudden they tolerate it perfectly. Like I have guys come back after 12 weeks who are really overweight, drinking a little bit too much, and I'm seeing them in my calendar, and I'm like, this guy's going to have all kinds of problems. And the only thing he complains about is that he has to shave his ball sack every second day. And I'm like, bro, this is not a problem. Like, this should be a dumpster fire. So there's definitely a lot to be said about changing the way the testosterone metabolizes in the body. And people like yourself who just subjectively experience it. I mean, if you've got years and decades of experimenting with different compounds, and you know what your baseline is, you know what placebo is, and you know what's legit, you can look at this and go, I feel different on this form, even though the amount of androgens is the same.
Oh yeah, completely. Yeah, completely different on, cream at 700 nanograms per deciliter of total test versus testosterone cypionate, completely different thing. Same thing with prop. Let me ask you, relative to cream, number one, what is your idea of the best dose of transcranial cream and also the frequency? And then number
Mhm.
two, how long do you give cream, given that it acts very fast, to like solidify someone's protocol before making a change? Like, will you give it 4 weeks, 6 weeks? Will you give it 8 weeks? I do think there's something to be said even for short esters, even though you can kind of dial in quicker. That still you kind of need to wait. So, what's your best dose, and how long do you wait on cream?
Yeah. So again, everything here that I've learned from Keith and Neil Rousier. They've been fantastic, kind of spearheading this initiative. So when it comes to cream, a big factor is the base that the cream's in. So the four most popular bases are the HRT base, the liposomal base, the Atrivas base, and I'm going to forget the other one, Versa base. They're the four.
Yeah, yeah,
So
yeah. Versa, yeah.
the HRT base is the best one because all these other creams were developed for all kinds of topical medication administration, getting it into the body. The HRT base is, from a physical standpoint, it feels like a good quality moisturizer or like a sunscreen. It's got some weight to it, but it absorbs very quickly. It doesn't leave like a oily residue, a powder, a smell. And it's made primarily from macadamia, nut oil, and olive oil. So it's very natural. But most importantly, it leads to drastically better levels. There's nothing wrong with the other options, but the HRT base will often only require half the amount of cream. And if you're having to put that on your ball sack twice a day before you pull your pants up, you want to put less of that on. It absorbs quicker, it's more comfortable, it's more affordable. I
Mhm.
mean, obvious reasons. So when it comes to the cream, there's a lot more individual variance. If you give 100 guys 200 milligrams a week of testosterone, you're going to get maybe 10 outliers and 90 guys who are about the same, within a ballpark of pretty similar. With cream, you get a bit more variance. So it is
Mm.
more important to start at a therapeutic dose and then check the bloods. You're completely correct, is that with cream, you can check the serum levels a lot earlier because it doesn't need multiple weeks to build up and up and up and up. It basically, I mean, you'd be at steady state within a few days, but it takes time to get the subjective effects to work. So I would, I recommend that if someone is overweight, hypertensive, other medical conditions going on, I think 50 milligrams of cream twice a day, which is typically one quarter mil click twice a day of a 20% transcranial cream is a good place to start. And then if a guy is healthy, he's previously been on injections, he wants to get right into it, I think 2 clicks twice a day is a great point to start at. Different people will recommend measuring levels at different points, because if you're putting on so the cream's got a 24-hour half-life. So depending on when you put the cream on and when you get bloods is going to make a big difference in your results. Most people recommend getting bloods about 4 to 6 hours after you put the cream on to get a nice midpoint. I recommend twice a day. Twice a day is always going to be the best because it gives you more stability. Some guys
And when you do twice a day, are you doing eight or so in the morning and then 7 p.m.? Or are you doing 4 p.m.? What's the second application? What time frame is that second
So if you were to do it once a day, you're basically going to be at a
application?
50% level 24 hours later. So given that we're keeping the levels more topped up per se, I'm more so about sustainability. So I do it when I get up and before I go to bed. So that time will
Okay.
kind of vary. I look at it
Okay.
kind of like, if I'm going to have 2 shots of espresso before noon, I don't really mind how they're spaced out as long as I get them in. So I'm kind of just
Yeah.
going, what's going to be easy for routine.
Yeah.
So yeah, just morning and night. Ideally, 12 hours apart would be ideal, but I don't think that makes a huge difference over time because the levels still remain relatively stable.
Okay. And let me
So
ask you. Let me ask you this: on guys that you do um, 2 pumps a day, just 2 pumps, like one in the morning and one in the evening. You mentioned that some of these guys might have health problems or whatever that make it so that they ultimately need lower doses of testosterone. Explain that to me. Like, how do you determine that a guy should should only dose a pump in the morning and then a pump in the evening? And
sure.
why do that? Like, do you feel like they're just going to have trouble tolerating higher levels? Is the estrogen going to creep up? Uh, you know, what's your logic behind that?
Yeah. So the way that I should have worded it a little bit better, that would be a starting protocol. So the idea for
Okay.
me would be, if someone is in a more kind of risk category, maybe they've already got high blood pressure, they've got other health issues going on. My goal with them at 6 months' time is to be optimal, but I'd rather kind of start with a more conservative dose and then put it up once they've gotten used to that. It would kind of like
Okay.
be if you were like, hey, I've never drank coffee before, but I get quite anxious. I'd be going, well, start with a half shot latte and then go to a full one and then kind of move up to a double espresso if you want.
Do you
It's
ever
the idea.
find that guys end up just that's a great analogy, by the way. Do you ever find that guys dial in perfectly on just a pump in the morning and then a pump later on in the day? Then you could just
Yes.
leave them there?
I've seen some guys get like 2,000. Like Keith sends me really really good case studies where like guys will get like 2,000, 3,000 nanograms per deciliter on like 1 click in the morning, 1 click at night. Like
Oh,
some guys are
whoa.
so sensitive to this stuff. Sometimes we have to reduce the strength of the cream because we can't reduce the amount of physical cream coming out. But
Right.
most guys, in my experience with the HRT base, to get the equivalent of about 200 to 250 milligrams a week of injectable testosterone, need about 2 clicks twice a day. And when I say click, that's a 0.25 mil click
Mhm.
of the HRT based cream. And then if it's a liposomal base or retriever base, which is less bioavailable, sometimes they'll need 3 clicks or even 4 clicks.
Mm. Okay. Now let
Twice.
me ask you about did you want to say something else? Was there another point you want to make?
I was just specifying it was twice a day in those
Okay.
measurements.
Yeah, got it. Got it. Let me ask you about SHBG. This is another one of those topics where you can't get people to fucking agree on whether it matters or whatever, or what the level is that starts causing problems. Do you find that with cream, because you are constantly elevating androgens and you really get no break, especially with doing twice a day, that lowers the SHBG in a place where it becomes problematic? If so, what do you do about it? And otherwise, generally speaking, relative to SHBG, do you find a lower level that becomes problematic, say below 10 or something?
Yeah, I
Yeah.
often say if it's single digit or triple digits, you might have a problem.
Yeah, right.
But that's a very broad, like over here in Europe, I've seen the range for SHBG go up to 80. Like in Australia, I think it
Mhm.
goes up to like 50, but the ranges really vary with SHBG. I see SHBG as a means to an end in terms of how much toto do we need to optimize the free. And if we're going to be using cream or a higher dose, that SHBG can move a lot. I mean, I see SHBG go from 50 to 20 all the time.
Mhm.
I strongly disagree with the idea that SHBG is a big factor in injection frequency because it doesn't impact the half life of the ester. It just impacts how much is free at any given time. it's definitely
Yeah.
a factor. I think the lower it is, the more it necessitates more frequent administration. But I
Yeah,
still think
or yeah,
it's
or a lot of testosterone at once or something. Yeah, I mean,
yeah.
it's just the literature is clear on one thing, that the lower it is, especially as you get to catastrophically low numbers, you're just clearing testosterone quickly. Most people have this very simplified understanding of it, is like low SHBG equals higher free testosterone, and that's good. But technically speaking, it is good, but it also means that you convert a lot of your testosterone into like urinary metabolites of testosterone faster. So
Yeah,
you
it's
don't want
if
it
you
to
look
be super fucking low.
yeah, if you look at it through one lens, it sounds great, but I mean, the body's the body's pretty fucking complex. So look, I think if it goes down into single digits, I mean, I think that that can indicate that one, I mean, sometimes there can be metabolic issues, underlying hypothyroidism, insulin resistance will cause low SHBG as well. So that can be a contributing factor. But I've never
Yeah,
seen SHBG go into single digits on TRT. I've seen it go into single digits when people take, high doses of DHT derivatives for sure.
yeah,
But I don't see
yeah,
SHBG tank on cream. No.
yeah. Okay, good, good, good. Yeah, yeah. Cream just seems to be like a really really close to perfect modality. You get the
Mhm.
DHT, you get some antagonizing action on estradiol. You can tolerate higher doses for sure than comparing it to injections. And I really don't think it's inconvenient. When I run cream, it's like take a shower in the morning. I fucking rub the. I'm usually just running 3 or 4 pumps or something in the morning, and I leave it go for 24 hours, and that suits me. But I
Yep.
don't find it to be inconvenient at all. I mean,
No.
it actually takes shorter of a time than having
Mhm.
to pull out fucking material from in a needle, and then you're injecting it, and then it's like it's
Mhm.
easy, honestly.
And it's much closer to bioidentical metabolism because it's just going straight into the bloodstream. It's not having to be bottlenecked and cleaved in the liver. So yeah, and that's stuff that Eric Serrano, Keith Nichols, Neil Rousier, they've all taught me that, and it makes a huge amount of sense. I see it in practice, like, and for me, like what I was saying before, like when you get like a big cohort of guys who wouldn't tolerate injections and they do fantastically on cream, that says something. The other thing for me is like, and when I was up at the Silverback Summit and we were all on stage, one of my questions for the rest of the panelists was like, "What do you all take personally?" Because I think that says a lot. Everyone was on cream, so
Mm,
when a lot of the guys who are practicing this personally as well as treating their patients are using the cream, I also think that speaks volumes as well.
interesting. Wow. Let me ask you to play devil's advocate regarding cream. I have a few people that when they dose cream too high, it almost seems like it shuts down the testicles more so. And I'm not sure that we can attribute that to elevated estradiol and suppression of the HPTA. Uh, I think there's some intertesticular mechanism going on there. Have you experienced that or come across that, or would you have any idea what that would be?
Like their balls get even smaller.
Yeah, 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 yes, yeah, quickly too, and it just and then it sort of starts to mute sexual function the same way that uh, people that require low doses of HCG or whatever doses of HCG
Mm,
in order to have sexual function, the same sort of thing happens to them.
sure.
Um,
I
I
I
don't
can't
I can't figure out what that is other than potentially like fuck man, intratesticular estradiol that's like super low. I don't know what it is.
when guys run high doses of tren and nandrolone, they'll often note that their testicles get closer to the size of like a raisin, and I think that's due to the progesterone effect of those hormones. When it
Hmm.
comes to the cream, I mean, I haven't heard that one. I would hypothesize, and again, this will just be a guess, that we know that testosterone stimulates the central nervous system. It's not a stimulant, but spiking it definitely activates the sympathetic nervous system. So I would wonder if they're kind of getting more of the testicular shrinkage that you'd get when you take like Adderall or Ritalin or something like that, where it's more they're kind of pulling up and shrinking like that. And they're
Hmm.
not having that proper therapeutic balance between sympathetic and parasympathetic because, sexual functions and erections are very complex, but the parasympathetic, the rest and relaxation is a big part of it. So I'd wonder if that could be at play, but I wouldn't know on that one.
It's a weird one, man. Especially because, and this could maybe segue into a different topic. Like I have been exploring the idea that DHT itself, taken exogenously, meaning DHT powder,
Mhm.
is can act as a replacement for HCG. for people that are having problems with HCG.
Right.
Uh, so it DHT being the problem doesn't seem to be like that's the problem.
Mhm.
So who knows? I guess we'll just couch that there and fucking leave it as an unknown for now. But
Mm.
relative to our discussion on HCG and alternatives, I have early experience that suggests that people can take low doses of exogenous DHT, 20 to 30 milligrams a day, and maintain not necessarily full testicular size, but they still shrink less. And all of the seminal fluid, the climax sensation, substantially better. And then they don't need HCG. Now, this is very, very preliminary. I don't have even 6 months of data on this. I've got like 3 months. I got one guy doing it for 4 months so far. And I got a lot of ideas on why this can happen. Literature suggests that DHT itself kind of acts as a backdoor pathway for testicular function because it recognizes, in the absence of luteinizing hormone, DHT can sort of act as a protector of
Mhm.
testicular function. We know that
Mhm.
proviron is, in some sense, prescribed as a fertility medication. Is it not?
In Australia, yeah.
Yeah, yeah. So I mean, there's I know every time I take Proviron, I definitely have just better climax function. Like
Mhm.
the ejaculate volume is better, the ejaculatory reflex is better. So I think folks really need to look into DHT itself. This is severely understudied. Like it's just not studied. You'll
Mhm.
find papers that say some of the stuff that I just suggested. It's like that's the only paper out there, the one that I just fucking referenced from my head. Um,
Mhm.
so it's severely understudied, but for sure there's something to exogenous DHT.
Mhm.
Probably somewhat replicable with either high doses of cream or a combo of cream and prop or high doses of prop, which have a protective effect on the testicles. What's your take on that? Have you seen that in practice? Have you seen that with cream or what?
I'm a big fan of DHT. I mean, the thing that we have in common is that we kind of got into this space from the neurochemistry side of things. I was more interested in how testosterone was similar to things like psychiatric medications rather than performance enhancing. And DHT is fascinating. I recently had a debate with Dr. Kyle Gillette about finasteride and DHT, and one thing that he
Oh
brought
yeah.
up, um, which was fascinating, was that, and I guess he was kind of on the opposite side of the fence, was talking about a lot of the potential harms of DHT, which we kind of agree to disagree on, would be more likely occurring from DHT that's metabolizing via the paracrine pathway rather than exogenous DHT itself. So when you take exogenous DHT, arguably a bunch of these potential hypothetical risks, or risks depending on how you interpret the literature, likely wouldn't be at play. I believe that a lot of the harms, particularly on things like the prostate and the cardiovascular system, that can occur from high doses of DHT derivatives are to do with the differences between DHT and the derivative itself.
Sure. Yeah,
DHT,
namely the lowering of estradiol or the antagonizing of the receptors in Masteron's case.
so DHT metabolizes into two really cool compounds that I cannot pronounce the name of, but they also work on the GABA system in the brain. And I liken DHT to a Jaeger bomb. It's if we look at a Jaeger bomb, we've got caffeine and alcohol. We've got the synergistic effect of the thing that's reducing social inhibition. So, things that make you more calm and more outgoing, and then something to uplift you and give you energy. And when we look at what DHT does, we've got something that increases dopamine and norepinephrine signaling, but also increases GABA signaling via allosteric modulation of the GABA A receptor.
Hmm.
That effect on a man's psychology is
Yeah.
literally the foundation for leadership. Like, that's the thing that drives you forward. That's the thing that gives you confidence. That's the thing that gives you resilience to stress. That's what all
Yeah.
these guys are looking for when they're saying, I want to be more of a man. So when it comes to what DHT is doing in the body, I think that it is undoubtedly therapeutic to virtually every system in the body. And
Yeah.
when you look into the literature for what it does, it's very difficult to find it doing harm in a human physiological setting. So I wouldn't be
Yep.
surprised if there was some protective function in the gonads itself as well. Absolutely.
Yep. Yeah, for sure. I mean, that's basically that underlies like what you just described in terms of the neurochemical profile of DHT's effect. It kind of describes the masculine feeling people get from Proviron or DHT. Like every
Yeah.
time I take the stuff, and I can repeat this in every client, they're just like, dude, I feel fucking way more like a man, way more like a man. So,
Mhm.
and that's a good point. Like if you can raise some of the excitatory neurotransmitters like the catecholamines and you can optimize GABA, that is a good state for like masculinity and
Mhm.
flow, especially. Yeah. Yeah.
Definitely.
Good point. Yeah, I think there's a lot more to be explored regarding the use of exogenous DHT. I got my hands on it, I want to say like 6 months ago or so.
Mhm.
And I had sources for it and was giving it to select few people with serious sexual dysfunction, really nobody else. But now I've kind of popularized the idea of using as I've talked about it a lot because it really is fucking mind blowing, man. I mean, I've done all kinds of really weird experiments, like where I made a testosterone gel, or correction, a DHT gel, and I strictly rubbed the gel on the perineum. And rubbing the
Yep.
gel on the perineum was a 4% concentration, dramatically increased and improved my ejaculate volume, my erectile sensation, and my climax sensation just from
Mhm.
rubbing DHT gel on the
Mhm.
perineum in the presence of a dialed in TRT protocol. So
Mhm.
it's like, yeah, there's it confuses me a little bit, like why the American pharmaceutical establishment has nothing to do with DHT. Like their only position is that it's bad and they can push finasteride on you. Like
Mhm.
that they're not. It's not prescribable at any capacity in any concentration other than in other your guys' countries over there, Proviron, which is not DHT.
Mhm.
It's a lot less potent than DHT, but it
Mhm.
shares similar, properties. Why do you think the medical establishment is just sort of like dissuading people from even thinking about DHT as a good thing?
It's too good. It would solve too many people's problems.
Yeah.
So when we look at the original studies on Proviron, so like for people who don't know, Proviron is arguably the closest to DHT out of all the derivatives. The
Yep.
problem with it
Yep.
is the bioavailability orally sucks, but originally it was studied as injectable. There was a phenomenal research paper that didn't really get properly completed where injectable Proviron was incredibly efficacious for depression in men, literally.
Mm.
For someone like you and I, we'd go, "Yep, that's what most guys need. A shot of Proviron would probably fix a lot of people's problems."
Yeah. Hell
Um,
yeah. Hell yeah.
so, I don't want to get too conspiratorial because it can kind of cause some people to tune out. But I think DHT for men can help in a lot of ways that bioidentical progesterone can help women. It's essentially like I don't want to get too woo woo, but DHT is your life force. Like
Yeah.
it's protective, it is stimulatory, but in a balancing way. And I think that it makes you more of who you are. It amplifies your internal traits. Sometimes that's a good thing, sometimes it's a bad thing. But makes you more of who you are, for better or for worse. But DHT is something that when guys are, if you look at the clinical symptoms of depression, and if you make a big list of this, I mean, my background was neuropsychiatry before I dropped out because this is how I learned about these hormones. I was like, what would be the perfect antidepressant? If we could make a list of all the mechanisms neurologically of the perfect compound to help a man get out of a depressive episode and to turn himself into someone who he's proud of, but also making effort feel good and drive him towards the things that he should be doing. It's literally DHT and its
Yep.
metabolites. So
Yeah,
I think
I fully agree. I fully agree, man. I think there's a paper on DHT as acting as an antidepressant. There's like one or two papers, but for sure, I mean, like, how different would the world be if instead of prescribing selective serotonin reuptake inhibitors, we were just giving people DHT? I mean,
this is something I'm a
dude,
big
yeah,
yeah.
yeah, me too, me too. Yeah, I think there's a lot of reasons for this. Number one, like if the American pharmaceutical establishment were to prop up DHT, it would just be completely antithetical to everything that they've been pushing regarding hair loss and finasteride. So that's one obvious reason, and I don't even think that's conspiratorially viewed or being conspiratorial. It's more like these guys are they're companies that the bottom line is everything, and so finasteride is a fucking massively profitable drug.
Mhm.
So to come out and say, hey, on one hand, if you've got hair loss, take finasteride and it will solve that problem, but cause a bunch of other problems which we won't tell you about, which we were sued to fucking to eventually elucidate, but we still try to keep under wraps. And then also this DHT stuff is a massive antidepressant and helps your sexual system and helps all these things and makes you feel more like a man. I just think it wouldn't work for them.
Yeah, completely. You can't patent a bioidentical hormone. It's all kind of fallen out of that realm. And um, yeah, I often say that if you took the average person living in Eastern Europe who wasn't doing well and you gave them a bit of thyroid, bit of vitamin D, bit of testosterone and DHT, they'd probably feel like Superman compared to how they felt previously within the matter of a few days.
Yeah,
And then the
completely.
thing that I think is the most exciting is how does that impact the trajectory of the next 5 years? I mean, like, if I look at the trajectory of how my life's changed in the 8 years I've been on testosterone, I took risks. I pushed outside of my comfort zone. I pushed myself hard for so many different reasons that I've ever, pushed myself before. And I'm so proud of the life that I've built and that I get to live. But previously, I was just like following the path of least resistance and hedonism because everything was more stressful and too difficult, and I was just lazy.
Yeah, for sure. Vigorous Steve talks a lot about this, and like I noticed running very high levels of testosterone that my productivity was like probably doubled. I don't think it was like I don't want to exaggerate the response, but it was very substantial.
Mm.
Where like as entrepreneurs, especially like fuck, man, testosterone is like a nootropic. Testosterone and DHT. These are nootropics essentially, insofar as how they affect your cognition and so long as you're managing your health and let's say you're doing it for brief periods, like entrepreneurs out there, like if you want to go in higher doses of testosterone and maybe deal with some of the side effects that might come, whether it's regarding the sexual system or otherwise, you're going to be fucking way more productive, man.
Hmm. Yep,
Yeah, yeah,
completely.
yeah,
And if we compare, like, what's the side effects of a slightly, we'll call it TRT plus protocol compared to 40 milligrams of Adderall a day. I know which
yeah.
one I'd prefer.
Oh yeah, for sure, definitely. Yeah, yeah, definitely. TRT or TRT plus Adderalls can be very mind numbing. People get into some serious black holes with that shit, and it takes sometimes a while to get them out.
Definitely, definitely.
Okay, what else? So in your guys's like so in your experience working with clients, are you ever suggesting or having people run DHT derivatives other than Proviron?
No, but that's purely just due to availability. So in Australia, Proviron is indicated for it is indicated for fertility. I'm not sure how it's used in that sense for guys who aren't on anything else, but what it's mainly still used for is for older men who don't respond properly to PED5 inhibitors for erectile dysfunction. So, if you're taking 40 milligrams of Cialis, 100 milligrams, 200 milligrams of Viagra, and you still can't get a proper erection, they'll tend to prescribe 25 to 50 milligrams of Proviron a day. That solves the issue.
Okay.
I can imagine why that would be the case. Um,
Well,
so
you should expand upon that. Is there some mechanism by which Proviron is enhancing the response to PD5 inhibitors? Like, I think there's many things like elevated prolactin will certainly make you not respond to PD5 inhibitors, but like, maybe you are PDE5 is upregulated at some level. I've seen some literature to suggest that that could happen. Like,
mm,
why would Proviron, improve the response to PDE5 inhibitors? I've seen some papers on androgens, specifically testosterone, doing that. It was like
mm,
intrapenile fucking PDE5, intrapenile nitric oxide or
mm.
something. But is there some specific mechanism by which this might be happening?
I think the potential local mechanism is that we know that there are androgen receptors in the penis itself. And
Yep.
if you only used provide, let's say you're an older gentleman and you only use Proviron before sex, maybe once or twice a week, it would probably hit you like a freight train. Um, I can imagine, though, the mechanism is more so that the proviron facilitates the sex drive, and then the PDE5 inhibition then supports the actual function of the erection. Um,
Right.
if these gentlemen are in their 70s and 80s, maybe they're not finding their 70 and 85-year-old wife as attractive as they did when they were younger. Maybe that's a bit of a
Right.
factor. Who knows? But the reason why we tend to use Proviron is that it's part of our medical system in Australia, so the
Yeah.
accessibility for it is there. Um,
Yeah.
I have worked with some guys overseas and coached them, when they were sourcing things themselves, which caveat I don't recommend doing, but if that's what guys are going to do, that's what they have to do. Um,
Good caveat.
Proviron and Primobolan, I mean, they're pretty damn similar outside of bioavailability and route of administration. I'd say
Yeah,
they're
and
they're
anabolism. And anabolism. Yeah.
yeah. So whereas Masteron is really estrogen antagonistic. So sometimes it can be, I mean, I think they're all usable I think they're all relatively interchangeable with different dosings and so forth. But I've just found Proviron is, well, the easiest for us to prescribe and access. But I've never seen 25 milligrams a day of Proviron do anything bad to the lipids or anything bad to the liver enzymes.
And
Whereas
this is in the context of not TRT or with TRT.
this is with TRT. So the time that I would recommend using Proviron would be one if transscrotal cream wasn't available for PFS. If someone's like, I've got post-finasteride syndrome, they tend to need a higher androgenic load to resolve the negative symptoms, which I know is something that you've spoken about as well. A client brought it up yesterday, actually, that he saw it in one of your videos, which I thought was great.
Yep.
But we know that PFS guys are resistant to androgens via some pathway. Don't know what it is, but they definitely are. They need more. So using Proviron allows them to simply tolerate more a higher androgenic load. So that's why I would be recommending it if the cream wasn't available or if DHT cream wasn't available. The other time that I would recommend it, again, if the cream wasn't available, would be if it was a younger gentleman who was starting TRT, let's say, sub 25. Maybe he's been on antidepressants, which I believe also downregulate 5-alpha reductase activity as well. But just a
Probably.
younger guy who's never had an ounce of masculinity in his body ever, I find that just putting in 6 months of Proviron at 25 milligrams a day can often just give him that grunt, that kind of masculine, like the surge that you were talking about before, to get up off his ass, to get in the gym, start setting some goals, just to kickstart getting him out of the rut he's in. When guys are off track, the further you are off track in life, the more difficult it is to get back on track. That's just the
Yeah,
reality.
for sure.
So
For sure.
if someone's in a deep dark hole with depression and they're not going to tolerate a higher androgen load because they're overweight or they're drinking a bit or they've got some stuff going on, I find that 25 milligrams a day of Proviron for the first 6 months can sometimes be a game changer in just getting them to be where they need to be, and then they can drop it off after a while if they no longer need it, which is what I
Okay.
did
Yeah.
last time.
Right. And now cream affects you the same way that effectively Proviron did, right? You were saying
Yeah.
something to this
Yeah.
effect. Yeah, interesting. Now, what is your take on regarding PFS people or anyone that's had 5-alpha reductase inhibited because hyperprolactinemia does that, as you discussed earlier. It just fucking shuts down the 5-AR enzymes to some extent.
Mm.
In these contexts where people require higher androgen loads, especially for erectile function, which to me is probably the DHT. Like, what do you think happens there? Because so if you're androgen deprived in the case of having inhibited 5-alpha reductase enzymes,
Mhm.
and you're androgen deprived for a long time, and especially deprived of DHT.
Mhm.
Does androgen deprivation uh, cause a situation relative to masculinity and sexual function that, though is fixable, takes longer?
Okay, yeah, good question. So again, we don't know, and that's one of the reasons why I fucking hate this drug is that we don't have literature to go, this is how this problem is occurring and this is how we can fix it, which is, as I said, why it's great that people like yourself are looking into this and getting in the trenches with it. My theory, and again, purely just hypothesizing based off what I've seen and what I've read, is that so we know for a fact that androgens upregulate in response to agonism, unlike dopamine receptors, which downregulate, which is why you get a tolerance. So I would argue that when the androgen receptor is deprived, it likely becomes blunted and downregulated, and then it
Mhm.
basically takes a higher load to net the androgenic effect that we're looking to get. I
I
also
think
wonder,
exactly that. Yeah.
yeah. And the other thing as well is that, like, I don't know about you, maybe you can share your experience, but I've had a bunch of guys, post PFS, they've still got symptoms. They've come off the finasteride though. And they're on TRT and their serum DHT levels look pretty damn normal. Like they're not, crashed out into nothing. Um,
Yeah.
and I would wonder if that at a intracellular level as a paracrine hormone, a hormone that's made within the cell, is whether the 5-alpha reductase enzyme is still damaged within that intracellular pathway. So there might be a bunch circulating around, but I don't really think that that's showing that it's having an internal effect in the cell. They're my two theories.
I completely agree with both of them, yeah, and especially that last one, like, we really can't see what's happening at the cellular level here. Like, there is a phenomenon of people having adequate levels blood levels of both testosterone and DHT, with estradiol being in a reasonable place and still lacking sexual function. A lot
Yeah.
of it, a lot of these people, the commonality between these people, the most, common commonality is androgen deprivation. Yeah,
Mm.
it's they were hypogonadal for a very long time, or they had very high prolactin for a very long time. It's usually just prolactinomas, or it's people that took finasteride, dutasteride, or fucking Rogaine, minoxidil. Minoxidil has the ability to cause these kinds of problems too. So, yeah,
Yeah.
I fuck, man, I often find myself in the comment section of my YouTube channel where people are like, a guy recently was like asking about topical anti-androgens, and he's like, I don't care about libido. I often find myself going, man, like you will when you fucking can't get it up for a date. And that happens for 3 years straight and you no longer can date. It's
Yeah.
just a warning that people really need to heed. Now, are people going to have sexual dysfunction from the use of finasteride? Is everybody? No, no.
Mm.
It seems that some people are somewhat resistant to it,
Mm.
whether their DHT is not being bottomed out or otherwise genetically they're resilient to this. But
Yeah.
yeah, it's Russian roulette, man. I don't think you want to play that game.
No, it's not worth it. Like there's 2 points I'll make. One is that I often joke that I don't know anything about women, but I know a lot about dudes. And I think that when it comes to men, drive is universal. Drive, sex drive, career drive, hobby drive, self development drive, it's all one and the same. So it's having a healthy sex drive is really important because you transmute that energy into other things, or it's really important for just so many factors in your life. You don't want to have no libido. Like that's just silly. But the other part that I'm concerned about, which is what I brought up in my debate with Kyle, is that I have concerns that even if, like, let's say you're someone who's going, oh, I'm taking finasteride and I'm not getting any side effects, and I don't have that issue. One is like, well, you don't know how you'd feel if you didn't take that. Firstly, so that's the other issue. But I
Right.
do wonder if the blockade of DHT or the reduction of DHT over decades for life could lead to things like early onset diabetes or early onset dementia. I wonder if that
Hmm.
would be neurotoxic, and that's my
Yeah.
concern.
Yeah, probably. I think probably. Yeah, I think I know which debate you're talking about, right? It was
I think
you
you
and
commented on it.
did I? Okay.
Yeah,
Yeah,
it was a
I then
while
I
ago.
had to have watched it. Yeah. So interesting. And what's that guy's position, by the way? Like he or what is his he's just a MD that prescribes finasteride to people? Is he like a hair loss specialist guy or what?
No, so Kyle's a friend of mine. He was originally the founding MD at Marek, and then now he owns Gillette Health, so his own clinic. His stance was still that guys shouldn't take this medication for hair loss, but basically being like, if guys are wanting to take it, then he was advocating the idea of using like a really minimal effective
Microdose. Yeah.
topical dose
Yeah.
of dutasteride, but still basically saying that we can't guarantee there are no side effects. And that's why it was
Right.
such a good debate because he was like, even on this side of the fence, I'm not pushing it on everyone. So it was more of
Yeah.
just sharing two sides of the equation.
Right, right, right. Got it, got it. Yeah, it seemed relatively cordial, which is good. I mean, it's good to have two people on somewhat different sides of this communicating about it and not being so extreme about it. Like the hair cafe guy, which prompted me to do a full fucking documentary on because he called me out on YouTube and was saying that the notion that DHT is necessary for sexual function is all horseshit. I mean that's an idea or an example of an extreme person regarding this stuff. So yeah, just folks take heed to those types definitely.
Yeah, definitely, 100%.
Okay, Dave. Well, so let's talk as we finish up here. Let's talk about your clinic. I don't know how much you've talked on the web about this, but if you want to kind of give my audience an idea of like what you're into right now, I think people want to hear it.
Yeah, yeah, absolutely. So, just over a year ago, we opened Primal Zone in Australia, which it was one of my original goals and visions when I got into this space was for people all over the world to be able to access like optimal TRT protocols and getting dialed in. Because when I first started, there was maybe one book written, and that was basically it. So, I've always wanted to create the content and then the resources that I needed when I started this journey, which is why I wrote my ebooks and then opening these clinics. So we've been up and running now for well over a year. Everyone who comes through Primal Zone has their protocol and blood work reviewed and weighed in on by myself. I don't have someone who is under me doing it. I do everything personally. Every file is done by me, and I'm really proud of that. We've built a really powerful system, integrated with MDs who speak to the patients. So everything's above board. Everything is done in a way that is completely audit proof, which is very important. And then over here in Eastern Europe, I live in Lithuania. We've just launched TRT Baltic, which is based out of Latvia, but it allows us to prescribe. We're only working with the transscrotal cream that we've been speaking about, purely just because logistically multi-country injections was too difficult. But we're able to provide remote telemedicine for all of Eastern Europe and Scandinavia. So all of these
Wow.
countries which previously haven't been able to get care, the doctor was trained by myself for over 6 months, so got him to a really, really high standard. And that way people are able to not just get testosterone prescribed with the HRT-based transscrotal cream, but things like pregnenolone, DHEA, thyroid, pharmaceutical-grade melatonin, tadalafil, all
Wow.
the other ancillaries needed. Um,
Wow.
but it's all remote, so people don't have to come and visit a country and get a prescription and fly back. I live in a tiny little remote village in Lithuania, and I get it FedEx to me within 36 hours. So
Wow.
that's been really exciting for me. And then I've also partnered with Victory Men's Health, which is a fantastic clinic in the US based out of St.
Yeah.
Louis. So for people who are stateside, basically it allows me to say, look, wherever you're living, you can go here, 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 and you can get a prescription and a treatment that's based on the direction and the overall perspective that I have in the space,
Yep.
which is what I've been working towards. So the other thing that I'll just quickly plug is that I've got a group on School called the TRT Academy. It's $19 a month, and that's got all my exclusive courses, all my exclusive content, and then a twice a week Q&A. So if anyone wants to jump in and join that community, that's also open.
Oh, I see it here. Okay, yeah, on School. Interesting.
Yeah.
19 bucks a month, the most comprehensive, educational, interactive, and affordable. So it's just videos of you and Ali and this Tom guy.
Yeah, so basically, I make it so because everyone lives in different countries. I'll open the Q&A a few days in advance. Everyone can upload their questions, and then I'll go through a video and explain it all. But then I'm also
Yeah.
working on exclusive courses as well. So a couple of courses have already gone
Cool.
up, and then
Cool.
I've got about 5 years of cataloged content. But if anyone puts a post in there, I reply to it. Everyone else in the community replies to it. It's a pretty solid group. I just wanted to make
Very
it
cool.
super affordable. I wanted everyone to be able to jump in and have some educational support on what they need. So
Yeah, hell
pretty
yeah.
happy.
20 bucks a month is easy, even if you're kind of broke. So that, and
That's
especially if
what I
you need
wanted.
this shit. Yeah,
That's what
that's
I wanted.
beautiful, man. Okay.
And
And then
the
your
the
clinic,
last
is
thing,
there a website for that?
it's just
Say that one more time.
so it's on advancedfundamentalhealth.com. There's a link for the school group there.
Right.
And the other thing I'll also mention is I've got 2 ebooks on my website. They're 29 Australian dollars. If anyone is particularly broke and would like a copy, just email me and I'll send it to you for free.
Sweet. That's very cool of you, Dave. This is TRT 101 and then what's the other
Beyond
one
TRT.
here? Beyond
So
TRT.
beyond
Fucking
TRT
app.
has got all the stuff that we spoke about on HCG today. That's one of the myths that I cover in there. So if anyone wants a
Yeah.
written copy of that and they can't afford it, just send me an email and I'll send you a copy.
Very awesome, Dave. Cool. And then so your YouTube channel is Advanced Fundamental Health, right? That's what it is.
Yeah, I'm most active on Instagram at I'm Dave Lee. That's kind of my main platform. I'm just getting on the YouTubes now, so I'm going to
Yeah.
be growing that over the next year. That's one of my goals, but it's been
Great.
a little bit of a on the back burner launching these clinics. I spend a lot of time doing clinical work every day, so
Yeah.
I'm getting a bit
Yeah.
more into the social medias for 2025. That's a goal.
Yeah, got it. Well, bro, we're all here for you on YouTube. So whenever you want to come on here, we can, chat and do a big long podcast to get people over to your channel. Whenever you want to give your channel more attention, let me know and we'll do some podcasts on both of our channels and we'll get it up there where it definitely deserves to be, man.
Awesome, man. Much appreciated. And as I said before, it's great to see you making some waves in this space. It's as I said last time, I think I first watched your videos back when you were doing them on paracetam. So
Yeah.
yeah,
Yeah.
uh great to see someone else has converged into this space via a similar pathway because the nootropic effect of testosterone is undoubtedly what's driven me to be where I am today. So
Yeah,
it's
totally.
awesome.
Yeah. I mean, yeah, for sure. For sure. Me too. Coming from the neuroscience side of this and nootropics, it's like everything that I try and everything that I take, like I noticed the neurological side of it, and that plays a fucking big role here in all of this, and it's just super. ongoingly exciting. So, Dave Lee, thanks for being on the podcast, man. I wish you the best. Chat with you soon, and I hope you have a great day, man.
Thanks, man. You too. Thank you for having me.